Okay, so the case I'm presenting is an 18-year-old male that I saw in the ED with no known past medical history, came in for evaluation of headache and double vision. The headache had been going on for a week by then, but the double vision had just started at the day of presentation. His headache was located in the right temporal area and had a severity of 8 out of 10. His double vision was horizontal and binocular. Also, his right eyelid was drooping and his right eye was painful. Interestingly, he had a very similar presentation at age 1 year. At that time, the day prior to presentation, he had a significant eyelid droop and difficulty with looking to the left. He was brought to the ED and admitted to the pediatric neurology service, and then his symptoms just resolved the next day and he was discharged. When I saw him, my physical exam revealed pupils that were equal and reactive bilaterally. He had right exotropia and primary gaze, impairment in right adduction, elevation, and depression, but abduction was spared, and he had right ptosis, so a pretty classic cranial nerve 3 palsy. He also reported decreased sensation in the right V1 distribution, but the rest of his cranial nerve and neurological exam was normal. This is the MRI brain that we got. So you can see the T1 plus contrast sequence on the left, and there's a bit of enhancement right at the tip of the right midbrain where cranial nerve 3 exits. On the left upper panel, you can see a blown up version of that. And on the left lower, I show you the anatomy of cranial nerve 3 as it exits in the ventral brainstem. So this condition is called recurrent painful ophthalmoplegic neuropathy. It used to be called ophthalmoplegic migraine, but the name has changed. It's manifests with recurrent bouts of head pain and ophthalmoplegia. It's pretty rare. Its incidence is 0.7 per 100 million. And usually the time of onset is under 10 years of age and in male children, although onset in adulthood has been described. The pathophysiology is unclear. It used to be thought that it was a migraine, but this has now become controversial because of the MRI findings that we have seen, and a migraine should not cause such weakness in the eyes. The most commonly accepted pathophysiology that I saw was that it's an autoimmune process. So it's caused by recurrent demyelinating neuropathy based on MRI evidence of enhancement and thickening of the ocular nerves as they exit the brainstem. However, enhancement is nonspecific and can be seen in other non-inflammatory conditions, so this is by no means a slam dunk there. Some people have postulated that it's an overlap with Tolles-Hunt syndrome, but that's we would kind of expect more cranial nerve involvement if there was a granulomatous spread there. So some more description of this condition. Usually cranial nerve 3 is involved, followed by cranial nerve 6, and very rarely cranial nerve 4, and these ophthalmoplegias can be isolated. The headache phenotype is migrainous in about 2/3 of patients. The interval between headache onset and ophthalmoparesis has a median of 1.5 days, but it can be delayed by up to 14 days. Headache lasts days to weeks, and ophthalmoplegia lasts a bit longer, so 2 to 3 weeks. It's usually side lock, and most patients have a history of migraine headaches outside of this episode and then have this episode. And about half have some sort of persistent deficits, although it's unclear how long these patients were followed up for. If you were to get an MRI during an attack, you'd see 75% of patients having an enhancement of cranial nerve 3, 76% have nerve thickening. If you were to repeat an MRI at some point in the future, most patients will have persistent but decreased enhancement, and then a minority would have persistent enhancement or like complete resolution of the enhancement. CSF was almost always normal in this condition, and ESR, if tested, is also normal. Here are some more MRI images that I found on the internet. So on the left, you can see cranial nerve 6 enhancing as it exits the pons. That's a more coronal view in panel B. And then on the right, you can see kind of a more distal enhancement. So the treatment is based on observational data. Most providers will use oral or IV steroids given for 5 days. About half of patients report it's beneficial, about 35% unclear if it's beneficial. Some report it's not beneficial, and a minority report that their symptoms worsen. The hope is that this usually leads to faster resolution of their symptoms, days compared to weeks. Permanent sequelae may be minimized, but again, this is not clear. IVIG has been used in one case with complete resolution, and some have tried preventative migraine medications such as verapamil and topiramate, but these are variably efficacious. So back to our patient, we admitted him to the neurology service overnight. We treated him with a dose of IV steroids and discharged him in a prednisone taper. And actually 10 days later, he was doing much better. His symptoms had mostly resolved, except for some mild residual double vision, but his neurological exam had normalized by then. This is an article I found very useful for further reading by Gefland. And thank you.
Thank you, Ryan. That was remarkable. Who would have thought? All right, now we're gonna turn it over to Kim Johnson, Dr. Kim Johnson, to introduce our speaker.
Okay, thanks, Rich. So today's speaker is Pierre Tariot. He attended medical school at the University of Rochester, completed residency in internal medicine and psychiatry at the University of Wisconsin, and also is board certified in internal medicine, psychiatry, and geriatric psychiatry. He started psychiatry as a faculty member at the University of Rochester Medical Center before moving to Arizona, where he's currently a research professor of psychiatry at the University of Arizona College of Medicine and the director of the Banner Alzheimer's Institute in Phoenix, a position he's held since 2006. His work there has mainly focused on clinical care and the study of people with and at risk for Alzheimer's disease, with an emphasis on design and implementation of clinical trials. So his experience with clinical trials includes conceiving, funding, and implementing single center and multi-center trials. He served as the principal director on over 50 clinical trials related to Alzheimer's disease and related dementia, and published over 400 papers. He currently serves as the co-director of the International Alzheimer's Prevention Initiative, which created and oversees pre-enrollment registries in Colombia and the US, including the Alzheimer's Prevention Registry and the Gene Match program. Recent trials include the autosomal dominant AD prevention trial crenezumab in cognitively unimpaired people destined to develop early onset AD in Colombia, which was launched in 2013, and the global APOE prevention trials known as the Generation program, or Generation 1 and 2, in cognitively unimpaired people at risk for late onset Alzheimer's disease that our own Jim Burke here oversaw here at Duke. So Pierre's latest launch is the Trailblazer 3 trial, which is an Alzheimer's prevention study in partnership with Lilly, assessing effectiveness of donanemab. So I always have a hard time pronouncing these monoclonal antibodies, which is a monoclonal antibody to amyloid in persons with normal cognition at risk for development of Alzheimer's disease, which started late last year in 2021 and runs through 2027. In the midst of his latest work with clinical trials, he also leads a clinical endeavor to increase the quality of care for persons with dementia by training health coaches to support families dealing with dementia in Banner's primary care clinics. So I think from all that I've said, it's clear that he's definitely devoted his life's work to Alzheimer's disease care and prevention. But in the midst of all this, Pierre also makes time for leisure activities and enjoys playing piano, walking his dog, and appreciating music, art, and nature. And I will add, he's a wonderful host. In 2019, we visited Banner's Alzheimer's Institute as a model for us when we were starting the ADRC here at Duke, and Pierre consulted with us and made us feel at home. So we're happy to have him here today, and he'll talk to us about the neuropsychiatric symptoms associated with dementia.
Thanks, Kim. Thanks, everybody. Will forgot to mention, for those who pay attention to these things, like my 6 grandchildren, that today is the 12th day of Christmas. So I wish you 12 drummers drumming. So you heard my credentials. Here are my actual or perceived conflicts. In a nutshell, I do a lot of consulting on protocol design and pipeline review. I don't do anything that's promotional or commercial. I think for this talk, what might be most relevant is my relationship with Acadia, for whom I've consulted for about 5 years. So I will move on. And we get lots of institutional research support from some of our pharmaceutical partners. Anything that I say about drugs today is off-label, period. So the FDA does not recognize any drug for the indication that I'm talking about. So please bear that in mind. That does not preclude clinical judgment, of course. So that's the situation that we're in. So, and then let's see if I can minimize this so I can see my slides. Great. So just to recap for this sophisticated audience, you know what dementia refers to: progressive cognitive and functional impairment, usually associated with neurological features. And I'm glad Ryan didn't present a case relevant to me, because I probably would have screwed it up. As I will emphasize several times, nearly universal incident neuropsychiatric features. And it's estimated that there are about 8 million persons these days in the US with dementia. And here's a rough, I won't read the slide, here's a rough breakdown of the likely etiologies. A point I'll come back to later is that when you use clinical criteria, there's actually quite a lot of overlap pathologically among the different dementias. But to the point of this talk, the lifetime risk of experiencing neuropsychiatric signs and symptoms, sometimes I'll use the word features, in a person with dementia is about 100%. A couple of key points I want to make here. I'm deliberately not using syndromal psychiatric diagnostic terminology, because in many cases, these features don't reach syndromal criteria. They're fleeting, they're fragmented, they come and go, they co-occur with one another, they vary a lot over time and between individuals. So I deliberately use somewhat descriptive terms like depressive features, anxious features, agitated features. The main focus of my talk will be on agitated and psychotic features. And then for the cognoscenti in the audience, I avoid using a widely used term called BPSD, behavioral and psychological symptoms of dementia. The trouble with that terminology is that most of these features are signs, not symptoms. So I steer away from that, what I believe is outmoded and slightly misleading terminology. The consequences, I imagine you know this, but if somebody has some of these features, they're much more likely to be functionally impaired, have a worse quality of life, die earlier, progress more quickly to severe dementia, cost more. I will mention, I don't think I mentioned to Kim and Rich when they visited, both my parents had dementia, and my mom suffered delusions and hallucinations in association with her dementia. And it was really tough for her, and when she was living with us, and even when she wasn't, quite hard on us. So I'm quite sensitized to the impact of this on the patient and the family. I think the other casual point I will make is that if you spent a day in our memory clinic, we see about 10,000 patients a year in our clinic. You would be impressed that we spend somewhere between 25 and 40% of our clinic day dealing with these kinds of issues. Let me start with agitation. Again, none of these indications are recognized by the FDA, although there are efforts to create systematic criteria that could be approvable. I like the definition that was proposed by a subgroup of the International Psychogeriatric Association and Yiska Cohen-Mansfield. Basically, verbal and or physical aggression, repetitive or hyperactive speech or vocalization or behavior or disinhibition. And these features have to be persistent, not present before the illness began, not due to some comorbid medical condition, and severe, dangerous, and or causing disability, injury, or distress. So that's what we tend to mean by agitation. I think there's a chance that the FDA will recognize this as an indication, but I don't want to get ahead of my ski tips, so to speak. In terms of criteria for psychosis, pretty common, about a 40% lifetime risk of psychotic features, a little bit higher than that for agitation. Visual and or hallucinations and or delusions in the presence of dementia. Of course, you have to exclude other obvious causes of psychosis like pre-existing psychiatric disorder, drugs, substance abuse, and so on. With the dementia unfolding before the psychotic features emerged, persisting for at least a month and severe enough to impair functioning. So these are the types of criteria that are out there for psychotic and agitated features. I've got about 10 or so slides with a case that I will blow through fairly quickly to use just to illustrate some of my teaching points. This is a true case with a few details changed to protect his or her identity. A 77-year-old woman, 77 at the time she saw me, incredibly healthy, except that she developed symptoms of dementia beginning at about age 72. She did not have a workup. She was in another state. Her primary care doc said, this looks like Alzheimer's, put her on donepezil at age 75. In retrospect, the family said maybe she was a bit more talkative, but over time, her English skills declined. She moved to be closer to a daughter, and the daughter brought her in to see me because of resistance to care, impaired hygiene, some verbal and physical aggression that was mostly pushing, irritability, and she was speaking less and less English. Basic functioning was intact. Complex activities were largely impaired. I'm not going to read all of this. Very clean prior history, only on donepezil, family history pertinent only for late onset unspecified dementia in her mother. She lived at home with her husband. She had an impressive professional career that included prior military service as an officer. Slender, 89 pounds. I'm an honorary neurologist, so take my exam with a grain of salt. At least I like to think I'm an honorary neurologist, but my exam was unremarkable. Disheveled, very distractible, going back and forth between two languages, vague word substitutions, repetitions. No evidence of psychosis that I could observe or infer. We play the guessing game of what's her mini mental. Kim, I won't ask you to say it out loud, but you could put it in the chat if you want. But here I go. We tested her in her native language and it was 9. I did the workup that had not been done previously, and there were no surprises in her laboratory or brain MRI findings. So I'm going to come back to this slide periodically. Think about what you would do, and then I will tell you what I would do. It's interesting when I present this case to our geriatric psychiatry fellows. There's a wide range of responses at this point. That typically I will just tip my hand a little bit here. A lot of people think about selective serotonin reuptake inhibitors at this point. Some fuss over, is this the right cholinesterase inhibitor? Some think about behavior management techniques. This is my most important slide, frankly. My second most important slide. Here's how I would approach a patient like this. Describe the behavioral features, which I did. I didn't get into the details about their exact frequency and timing. I will come back to that later. Is this an emergency? I would say no. What is the dementia? Because that matters to some extent. I think it's probably Alzheimer's type dementia, but at her age, there's a very high likelihood of coincident other pathology. I don't think she's delirious. I don't see evidence of pain. there is not a pre-existing or comorbid psychiatric disorder. So one of the things we're going to feature early on in a non-emergent case like this is working together with the family and, to the extent possible, the patient, to come up with a humane behavior management plan. And this is my most important slide, cut off on my screen, but I hope not on yours. We are very fortunate to have a multidisciplinary and interdisciplinary team that allows us to work with experts in psychology, social work, nursing, and to some extent physical therapy and speech and language therapy. So we work together as a team to try to figure out how to help. And again, I'm not going to read the whole slide, but it's amazing how often environmental stressors are key, how often simple techniques like extinction, not responding to the behavior, distraction, can be helpful. When Kim is taking care of me in the nursing home, because that's who I want taking care of me if she's willing, when I start getting riled up, I want the aides to hand me an ice cream cone and say, there you go, because I will probably settle down very quickly. Structured activities are incredibly important, sometimes sensory stimulation, social contact and routines, very important. And if you remember only a couple things from this slide, one would be, what is the patient trying to express about her needs? What are her unmet needs that are coming through in this fragmented way to you? And could she be in pain and you don't know it? If you have the luxury of disposable time, read a piece called A Sense of an Ending in the New Yorker from 2013 that describes a nursing home unit in Phoenix that we helped set up, where patients with advanced dementia, about 40 at a time, are cared for without use of any antipsychotics or major psychotropics, strictly behavior management techniques. This is the gold standard when we have the luxury of time and enough staff. These approaches often, if not always, work. The trouble is, very few of us have the luxury of that level of intense resources. If you back up and take a look at meta-analyses of non-pharmacologic approaches of the many, many types that have been studied, relatively few work, usually interventions tailored to the individual needs of the person, teaching caregivers how to communicate, promoting regular activities, and to some extent music therapy. We did a music therapy study, and the only finding was enhanced mortality in the music group. So in this particular case, I'm going to keep coming back to her. We focused on what I've just talked about, education and support, planning ahead. They hadn't done legal and financial planning, by the way. Talked about how common this is, distraction and extinction techniques, focused on comfort. I elected to continue the donepezil with food. I did not initiate any other therapy. Things got better enough that they didn't need to see me again until 6 months later, when the same problems came back. I was able to establish that there was no new illness. The exam was really about the same. There wasn't much new on the social scene. So what would you do now? And obviously what I'm tilting you toward is thinking about pros and cons of medication. Although, some true blue experts would continue focusing on number 7 here as the sort of ideal approach. Believe it or not, I still refer to an article I wrote 40 years ago that essentially says, look, if you're going to use drugs, try not to. You do all the other stuff first. But if you're going to use drugs, think about as best you can, which type of dementia is it, because that may matter. And then when you think about the behavioral features that you're faced with, even though they're fragmented and don't meet psychiatric syndromal criteria, do they look more like one type of psychiatric disorder than another? So she's, quote, agitated, and verbalization is fragmented, but you hear themes, excuse me, along the lines of loss, sadness, death. She's intermittently tearful, and maybe maybe irritable and anxious. That begins to look depressive to me, and I would certainly think about antidepressants. We used to talk more about anticonvulsants, but we don't anymore, as I'll come back to. On the other hand, if she's, quote, agitated, but recoils when approached, makes fragmented references to perhaps seeing things or believing things that might not be real, that begins to sound more psychotic, and I might be thinking about an antipsychotic. No matter what, if we try a medication and it doesn't work, we need to stop it. And even if it does work, we try to stop. These are sort of the fundamental principles, some of which are sort of reified in recent American Psychiatric Association guidelines on the use of antipsychotics in this population. So let me just blow through these categories of drugs that are considered. What about our antidementia therapies? There is some evidence, especially from meta-analysis, suggesting that if you start them before behavioral features are present, you might delay their emergence. And we believe that inconclusive data, and we treat accordingly. Some individuals who have symptoms can show reduction, but this does not show up often at a group level. Some meta-analyses suggest this, but I think in the aggregate, you've got to be skeptical. Actually, just a couple of days ago, a Cochrane review came out that I found notable because they're so agnostic. They reported that from their perspective, removal of cholinesterase inhibitors is associated with re-emerging neuropsychiatric features, as well as cognitive and functional decline, something that has been shown by studies, but not widely grasped by clinicians. But there wasn't evidence that allowed any conclusions about withdrawal of memantine. We do see occasional deterioration after stopping memantine, even if we think it isn't working. So again, soft evidence, but since these should be used anyway, particularly if the person meets criteria for Alzheimer's type dementia, we would suggest this is first line anyway with medications. So with this gal, the first thing I did was at that point, since she had moderately severe dementia, I thought of the Alzheimer type. I started standard formulation memantine, titrated it. She had no side effects, seemed, quote, a bit more like herself, a bit more talkative, calmer. And so it went for almost a year. Then at age 79, she really deteriorated precipitously over a couple of weeks, began attacking her husband, insisting that she was robbed or that she was being poisoned, very angry, enraged when her husband attempted to interact with her. They brought her in on an urgent basis. We saw her same day, which we can do often. Instead of having her go to the emergency room, at that point she had lost about 10% of her weight, very disheveled, aggressive toward me. I won't read everything, you can see what she was like, and literally flew into a rage whenever her husband showed up, and none of us could redirect her. So what would you do at this point? I think in most communities, this woman would be sent to the emergency room. The trouble with that in most communities is what that results in is either discharge to home with prescriptions for antipsychotics and anticonvulsants, or short-term admission for sedation in a psychiatric unit. if there's a room available until she's sedated and stiff and calmer and sent home. So that's not our preferred option, but I want to be honest that in a lot of situations that's what would happen. So I'm going to go through the classes of agents. I'm going to show some visuals that I will not dwell on. Here's one of them, just to make the point that yes, there have been trials of antidepressants, including one just published a couple days ago in Lancet at the bottom of a drug we don't use, frankly, for this purpose, mirtazapine. It's actually the largest of any of these trials. The bottom line is none of these trials really showed benefit. What's considered maybe the flagship study was called CTAD, citalopram versus placebo. Here's the takeaway. It was for agitation in clinically diagnosed Alzheimer's dementia. Citalopram did seem to have modest clinical benefit on primary and secondary measures, with a whole bunch of side effects on the right that I won't read, including prolongation of the QTC resulting in a change in the label. That label change, by the way, has been criticized, but it still stands. Most of the same investigators are now conducting a study with escitalopram, which would be very logical. You would think it might have the same pharmacological effect with better safety, and it remains to be seen. So citalopram sort of pops out as a potentially therapeutic option for somebody like this. Then it let me just do the visual with some selected anticonvulsants. I'm not going to read all of this. I'm responsible for a fair amount of these studies, including single center and 2 NIH-funded multi-center studies. Divalproex clearly did not work in large studies. Carbamazepine seemed to show benefit in small studies, but perhaps thankfully nobody has conducted a large randomized trial, because that would be very difficult and dicey in terms of risk benefit. Let me show you the top line result from one of our NIH-funded trials. We had the idea of, let's take a few hundred people with Alzheimer's type dementia who haven't been agitated yet, randomize them to tolerable doses of divalproex or placebo, and see if we could stave off emergent agitation. Here's the Cox proportional hazard data. No difference over 2 years. It had no benefit in terms of attenuating emergent agitation. It was actually also the first multi-center trial that embedded MRI. We had the thought, in retrospect, you might call it a fantasy if you're a psychiatrist, that there might be neuroprotective effects of divalproex based on HDAC inhibition and some other mechanisms. And lo and behold, without getting into all the details, we found the reverse. Placebo divalproex, looking at hippocampal volumes, ventricular volumes, whole brain, there was a substantial worsening of atrophy on drug versus placebo. As Ryan probably would tell us, this is seen in children, and in the label for children, and now in the label for older people. The mechanism is unknown, but it may not be a good thing for your brain. So the takeaway for anticonvulsants is, despite the promise people wish they would have when studied, they have not shown benefit. There is insufficient evidence to use them routinely in clinical practice. And yet, they are used frequently in clinical practice. We don't use them, even when we're painted into a corner. What about benzos? The bottom line is we avoid them if at all possible. The surprisingly limited clinical trials data shows limited efficacy and high rates of cognitive impairment, falls, and fractures. I personally don't practice with an eye toward legal vulnerability, but one wonders about that in using benzos. They're also very difficult to discontinue, particularly in this population. We tend to only use benzos for situational, time-limited situational issues, such as she becomes grossly physically aggressive with bathing, and so there you go, or an MRI or dental procedure, something like that. We recommend using longer half-life drugs such as lorazepam. We definitely want to avoid drugs like temazepam or alprazolam, which I jokingly refer to as the devil's drug. Here's another couple of visuals. Yeah, I'm moving on to antipsychotics. There have been maybe 40-ish randomized controlled trials of reasonable size and design of different, mostly atypical antipsychotics, some with older antipsychotics, which we consider passé these days. Again, this is just a visual, but over on the right, you see lots of negative studies or marginal p-values. Here are a couple more examples. I'm going to summarize in the following slide a meta-analysis that I still refer to, published by Lon Schneider and colleagues 15, 16 years ago, but it's frequent, it's held up. It's frequently replicated by other meta-analyses, including one done by the FDA. So here's the takeaway. The average treatment effect was less than 20%. That is to say, drug beat placebo for the treatment of agitation and or psychosis less than 1 time in 5, with around an 80 to 90% toxicity rate. So the risk-benefit ratio is terrible. It doesn't mean you can't or shouldn't use these medications, but you have to be clear-eyed about risk-benefit. You have to explain risk-benefit to everybody involved, including the family, and to the extent possible, which is frequently not possible when you're using a drug like this, the family, the patient. Please look at all of the safety problems that emerge, because you will see some or all of them. In my mother's case, with severe psychosis, she was treated with an atypical that caused her to become somnolent. To my horror, she fell and had fractures, resulting in hospitalization, edema, Parkinsonism. There was no middle ground for her. She was either psychotic or basically sedated and Parkinsonian. It was a terrible dilemma. Sophie's choice. You must know, I'm sure, that Lon and then the Canadian Health Authority and then the FDA all found the same thing, that in placebo-controlled trials of the atypicals, there is a death signal, almost doubling the death rate on drug versus placebo. This was subsequently found with retrospective cohort studies of conventional antipsychotics. So there's a black box warning about use of these medications in older persons with dementia. Again, that doesn't preclude clinical judgment, but you have to be clear-eyed about this risk. Instead of showing you a bunch of those studies, I'll show you what I think is the largest NIH-funded study of atypicals in this population, called CTAD. Duke participated in this study, was a major player in a variety of ways. So this was an effectiveness study in over 400 persons with clinically diagnosed Alzheimer's dementia complicated by agitation and or psychosis. Persons were randomized to these 3 drugs in first phase or placebo, and the primary outcome was how long before the principal investigator said, I quit this drug and I'm going on to phase 2. Here's the primary outcome. I actually mixed some things here in my haste to get these slides done. The primary outcome, bear with me a second. Okay, so I mixed up my slides. The primary outcome showed no difference between drug and placebo. There was no difference in time to discontinuation for any reason. And that's shown by the data on the left. The graph on the right, which is misplaced, I apologize, is one of the secondary outcomes, which was time to discontinuation because of lack of efficacy. And there, olanzapine and risperidone were slightly better than quetiapine or placebo. The other key secondary outcome was time until discontinuation for safety concerns, and placebo beat all the other drugs by a mile. And that's, sorry for my mix-up there. This was published in the New England Journal. You can get the details. Here in red are the key adverse events by treatment arm. I've mentioned all of these before, but just again, giving you an example from one trial: Parkinsonism, sedation across the board, not just quetiapine, that's an urban legend. Worsening cognition in one treatment group, interestingly worsening of psychosis in the same one, and confusion. So the takeaway was physicians were very quick to discontinue this phase 1 treatment. Doses were low, but enough to cause toxicity. The bottom line is that very few patients were helped without being hurt. Many were only hurt, and some were both hurt and helped. And that's what you see in the clinic. I would be remiss if I didn't mention some of the long-term effects of atypicals that I didn't mention before. So risk-benefit is not good. It's for this reason that the company called Acadia that developed Pimavansarin and has Pimavansarin approved for the treatment of psychosis due to Parkinson's disease. I helped them develop a program, a clinical program, to look at Pimavansarin in dementia. The Parkinson's study that Jeff Cummings was the first author on had a pre-specified analysis of psychosis reduction in people with mini-mentals in the range of 20 to 24. You couldn't be in the study if you had a primary diagnosis of dementia, but it was a first look at, well, what if they were cognitively impaired? And that subgroup did very, very well in terms of reduction of psychosis. That led to a single center, multi-site nursing home trial in England led by Clive Ballard in persons clinically diagnosed with Alzheimer's dementia. That's what's depicted here. The primary outcome was ratings of psychosis at 6 weeks. The study was continued beyond 6 weeks to try to get a handle on whether there were any long-term cognitive effects. There was a positive drug placebo difference at 6 weeks. It disappeared at week 12. I won't get into the details of rationalization for that. It was a phase 2 study considered reasonably positive. And the drug was very well tolerated in this population. That led to the so-called Harmony study that was published a few months ago in the New England Journal. I was the first author. Again, I have a paid relationship with Acadia as a consultant, and I helped design the study and get it reviewed with the FDA, and I chaired the so-called adjudication committee. This was a relapse prevention design, that is to say, several hundred persons with all comers dementia, a very important change there, who had to meet operational criteria for psychosis. All were treated with open label Pimavansarin, and then only those who had a sustained response at 8 and 12 weeks of open label treatment were eligible to go on to the double-blind phase, where they were randomized to ongoing Pimavansarin or placebo, the primary outcome being survival until relapse or recurrent psychosis. So roughly 2/3 of people were eligible for randomization. And here's the primary outcome. The study was stopped early because of a nearly 3-fold difference in hazard ratio on drug versus placebo. There's a pre-specified statistical analysis plan that led to this decision. The key secondary measure was time to all-cause discontinuation, which looked quite similar, and tolerability was good. Interestingly, the FDA that had previously said this could lead to an indication for Pimavansarin to be used for dementia-related psychosis changed course, in part because the subgroup with clinically diagnosed Parkinson dementia showed the most robust response in this trial, although other subgroups did as well, dementia subgroups did as well. This has been an ongoing behind-the-scenes saga. Acadia just issued a press release last week saying that they are proceeding with discussions with the FDA about seeking a label for psychosis due to Alzheimer's dementia. So it remains to be seen what will happen from a regulatory standpoint. I'm pulling into the home stretch in here, hopefully on time. I do want to acknowledge that there are multiple new drugs being looked at for agitation, and I should say psychosis as well. I'm not going to dwell on all of these. It's early days. I sort of repeat the Pimavansarin reference here. If I were to single one out, it would be brexpiprazole, which has been developed by primarily Otsuka and has shown benefit in 1 out of 2 multicenter trials of agitation. So a third one was launched. It remains to be seen what its fate will be. But the main takeaway here is, yes, there are other drugs in development besides the ones I've talked about. So here's what happened. I'm reminding you what she looked like, what my patient looked like, what her exam was, and quite striking, her reaction to her husband. I hope Kim's wheels are turning about what that might signify. What did we do? We did not send her to the emergency room. I elected to start her with an unspecified atypical antipsychotic and essentially do a false hospitalization, as I will explain. This is an off-label maneuver. I don't mean to suggest that everybody should do what I did, but this is what I did. And for the reasons, based on the evidence that I've just reviewed with you, that atypicals can help individuals with a high rate of side effects. Instead of sending her to the hospital, we moved her husband out of the house and her daughter moved in. And she was easily sort of susceptible to intensive behavior management training. We emphasized very basic things about nutrition, hygiene, routines, sleep schedule. She was too agitated to do a delirium workup until about a week and a half later, at which point we established that delirium wasn't the cause of her worsening. Her husband was able to move in. And when he did, once again, she kind of went bananas, to use an intense psychiatric technical term, every time he approached, especially when he touched her purse. And we eventually realized that she didn't quite understand who he was and assumed he was robbing her when he did that. So we said, please leave the purse alone. And that alone was a big help. We did try to taper the antipsychotic every 3 months. It was a low dose. She did fairly well with mild Parkinsonism. We didn't even want to have that as a liability. But every time we tried to taper the drug, she got worse. This would be consistent with APA guidelines, by the way. Try to taper when you can. Her dementia gradually progressed. She was placed in memory care. Later in life, 4 years later, we were able to finally stop the antipsychotic, and she died of pneumonia at age 85. So last slide. So, key takeaways. Neuropsychiatric features are common bedfellows with all the dementias, with psychosis and or agitation kind of leading the pack in terms of adverse consequences. No drug is FDA approved for treatment of any behavioral features. When we're stuck with severe agitation or psychosis and behavior management techniques have failed, and I should say SSRIs, we frequently try them. in addition, of course, to the antidementia medications. If we're painted into a corner, we will reluctantly use atypical antipsychotics, making it very clear to all stakeholders what the risks are and the low chance of benefit. So I will stop there and see if that leaves us time for any questions.
That was just a great talk, and it was also an incredibly humane talk. And when you're in your nursing home with ice cream, I'll be in the bed next to you with my ice cream, and Kim will take care of both of us.
No wine for you?
No wine, beer.
Oh, beer, okay. Beer and ice cream. You got that, Kim. Okay.
And go together well. So Marvin, do you want to ask the first question?
Oh, trazodone. Thanks. Great question. I blew past that. We participated in the study published by Linda Terry looking at trazodone versus haloperidol versus behavioral techniques, which didn't show an effect. There are some small, it's one of these deals where the smaller the study is, the more likely it is to show the potential efficacy. So there's some small studies showing benefit of trazodone. So you're really left with your own clinical experience. I will say we would not use, this is just clinical lore here, we would not use trazodone unless really our primary target was sleep. So if somebody was mildly to moderately irritable or agitated and sleep was a big problem, we might lead with trazodone. Otherwise, if we were thinking we could get away with something short of an atypical, we would use a more traditional SSRI. Jim's asking about THC. That was on the list of drugs in development. I'm embarrassed to say, but I have to say, that our families are way ahead of us on this issue. At last count, we have 150 families using cannabinoids on their own for a variety of things in our clinic, including pain, sleep, and agitation. There's I hinted in my New Direction slide, there's a very small study out of Canada suggesting possible benefit of cannabinoids that has led to a multi-center trial in Canada. Jim and the folks at Duke are probably aware of the NIA-funded trial of cannabinoids in end-stage dementia associated with agitation. So it remains to be seen. The reason I'm embarrassed is I wish we could give patients and families guidance, and we can't. We do refer anybody who's interested to a specific naturopathic clinic in our community that is very rigorous in their approach to use of cannabinoids. And I'm curious if anybody at Duke wants to comment further. But hi, Kathy.
Here, I've got a couple questions.
Okay.
First, ECT.
So thanks for bringing that up. I actually published a very detailed case study showing remarkable efficacy of ECT. We reserve it for essentially last ditch intervention, but it could be effective, but used rarely.
Okay, so in the opposite end, the placebo response, is there any way to tap into that? I mean, if you get a 30% benefit from a placebo for psychotic features, what does that even mean? And how do we tap into it?
Well, Hawthorne effect. I mean, I realize we're out of time, but if you
we have the time, we can just, anyone who needs to leave can leave.
Okay, but if you've got, let's say, a nursing home resident with advanced dementia, age 88, and he or she is agitated and psychotic, and you parachute in an attractive research team that pays attention to her and trains the staff and gives her a pill and talks to her regularly, she's going to do better. There's no question about it. That makes me hark back to the New Yorker article called A Sense of an Ending. If you pay attention to these people, imagine just giving her a foot massage, for heaven's sake. Yeah.
All right, Kim, you had a question? Thank you.
Yeah, I was wondering, do you ever prescribe Pimavansarin, and do you have any success getting it approved? So I've got so many like just very psychotic patients with dementia that I'd love to try it on, but I just can't get it approved.
Yeah. For those who don't know, Pimavansarin is available only through a kind of registry restricted to persons with Parkinson's disease, and it's virtually impossible to get an exemption, except under humanitarian considerations, which you could consider. I want to be very cautious about what I say about Pimavansarin because of my financial ties. I did oversee one of our nonprofit institutes for 4 years with a movement disorder program, and I'll talk about my colleagues, not me, our Parkinson's experts used Pimavansarin as their first choice in Parkinson's disease complicated by psychosis. Not a miracle drug. It was frequently, but not always effective, and sometimes there was poop out, and they would end up using off-label adjunctive therapy. And Carmelo Graffinino offers to everybody an anecdote about prescribed THC. All I can say is we hear this type of anecdote from our families and have to confess there's little evidence for agitation. Corey Myers, let's see, behavioral interventions, too advanced to benefit by them. I don't think so. I don't.
Or Pierre, cognitive behavioral therapy.
Oh, cognitive behavioral.
No, or mindfulness, both of them.
CBT or mindfulness, no, but simpler techniques, as I mentioned, such as distraction and extinction and reassurance. It's amazing, and simply the caregivers understanding that their own comportment will affect the behavior of the patient. That was the secret to success in this nursing home called the Beatitudes in Phoenix.
So Pierre, one thing that would be really helpful to us is a good book we could give caregivers that could go over this kind of stuff. There's so many out there. Is there one that you find particularly useful, or even we could read it?
Didn't we give it to you, Rich? The one we wrote?
You have one? Okay.
We for that very reason, we have written a guidebook for our families, and we tell them don't read it, skim the table of contents and focus on what's relevant to you. So we have what we call care tips,
okay,
to help people, and happy to send you a new copy.
Oh, really? And when I give them, tell them about the 36-hour day, I said, it's the Bible, and by that I mean it's as big as the Bible. And same thing, skim it for something that you might be interested. Kim, got another question?
Yeah, I was just wondering if you could talk a little about your program with the coaches in primary care, and if that has helped manage behavioral symptoms at all. So it's just hard because we're so limited as providers, and how do we disseminate information?
Yeah. Just to set a little bit of context, and again, I apologize that we've run over. We are training a new type of workforce to see if that can help improve the care of persons with dementia being cared for in the primary care setting. So these are high school, some college graduates who have no healthcare training or experience, crash course in all things dementia and ongoing supervision. And they meet with the patient and family to identify what the most salient problems are in day-to-day life, ranging from safety to hygiene to behavior, whatever. Frequently medication mismanagement, frequently unbelievable safety issues, ranging from guns to drugs to unsafe home environment. But when it comes to behavior, we focus on these basic techniques that I've talked about. I can only give you anecdotes. By the way, the program description has been published in the American Journal of Geriatric Psychiatry, if you want to take a look. But yeah, we definitely have the anecdotal impression that teaching these simple techniques to caregivers can be quite helpful and seem to be achieving one of our most cherished goals, which is avoiding avoidable emergency room visits and hospitalizations for behavioral indications. But like, I can't tell you yet that we've proven that.
Again, back to the practical, I seriously doubt handing a patient a book does them any good. Is that your impression? Some of them will absorb it, but the majority won't even look at it.
Well, just to use our so-called dementia care partners program as an example, our focus is the care partner, frankly, more than the patient. We think that that's where we'll have the most success. And there's a wonderful geriatric psychiatrist named Craig Nelson, who used to be at Yale, and he's at UCSF now, who taught several generations of geriatric psychiatrists what's the most effective thing you can do when faced with a behavioral emergency in somebody with dementia, which is to sit down and talk calmly with the caregivers. Don't get carried away by the moment. Just sit down, ask them to describe what's going on, just by your own demeanor, conveying a sense that this we can sort this out. It's amazing, frankly, how much that alone makes a difference.
Pierre, that was remarkable. And I was about to jump out my window as your talk went on. Nothing. But you give me hope again, and all of us.
Yeah. All right, team. Well, good luck. Stay warm, and it'll be sunny and warm here today.
Thank you so much.
Take care, everybody. Hi, Kathy. Nice to see you. Bye, folks.
Bye-bye.